What kind of cataracts do you find challenging? As you perform surgeries, you'll often come across cataracts that are unexpectedly tricky. Today, let's talk about one of those types. They might seem easy at first glance, but they can definitely catch you off guard. Soft but sticky cataracts. This is a cataract patient in their early 60s. The cataract shows minimal nuclear sclerosis, but has severe cortical opacities. This type of cataract has a few key characteristics, and understanding them can make it easier to handle. Let's take a look at a few surgeries to understand this better. Cortical opacities can obstruct the red reflex, so it's best to turn off oblique illumination and rely solely on coaxial illumination to make the most of the red reflex when performing CCC. In this case, the view provides enough clarity to proceed carefully. However, if there's even the slightest uncertainty, staining the anterior capsule as shown in similar cases is advisable. For beginners, if you're unsure whether to use anterior capsule staining or tools like iris retractors, just go ahead and use them. It's best to perform the CCC more slowly than usual. The opacities are often concentrated along the edge where the CCC margin passes, which increases the risk of losing the flap. Take your time focusing on the flap margin and move steadily to a clear, non-cloudy area in one motion. Stopping occasionally in brighter, clear sections to reposition the flap is also a good strategy. For cataracts that are sticky and tightly adhered to the capsule, hydrodissection is arguably the most critical step. However, these types of cataracts often make hydrodissection more difficult than expected. As shown in the video, when BSS is injected, the view can become very cloudy, and the red reflex disappears, making it hard to assess whether the hydrodissection was successful. Additionally, hydrodelineation is frequently ineffective in these cases. In some instances, as seen in the video, hydrodissection might not be possible at all. Thus, it's essential to periodically press down on the nucleus to relieve any anterior capsule block and ensure thorough hydrodissection. If the cataract is very soft, prolapsing the nucleus, as demonstrated in the video, can also be an effective technique. Mechanical chopping is particularly useful in these cases, and it's best to use a 2 mm long blunt tip chopper. When the nucleus is soft, a shorter chopper tip makes it more challenging to split the nucleus effectively. Clear out the messy cortex to secure a better view. Always ensure that the nucleus rotates freely. The smoother it rotates, the better. Simply rotating the nucleus helps to separate corticocapsular adhesions. Hook the chopper firmly onto the nucleus equator before performing mechanical chopping. Let's watch it again in slow motion. Secure the chopper tip firmly on the nucleus. For typical chopping, the vacuum is used to hold the nucleus, but with soft nuclei, it's neither necessary nor effective. A slight counterforce with the phaco tip is sufficient. Thanks to the angled design of the phaco tip, simply pressing it gently against the nucleus, almost like using a knife, will suffice. The chopping happens smoothly, as if slicing through melted ice cream. One critical point: avoid shallow chopping. This is especially true for softer nuclei. If the chopper tip is shorter than 2 mm, go even deeper than shown in the video. Another characteristic of sticky cataracts: every time you chop or divide the nucleus, a lot of debris clouds the view. Periodically press the foot pedal to clear the field of vision. Now it's time to remove the nuclear fragments. Never use excessive vacuum or ultrasound, especially near the periphery. Even if the fragments seem well separated, their sticky nature can cause them to remain attached to each other or the capsule. potentially leading to posterior capsular rupture. Gently grasp the fragments with minimal vacuum and bring them toward the center. If this doesn't work, don't force it. Instead, rotate the nucleus and target any fully detached fragments. What about even stickier cataracts? This is a case where the nucleus was previously prolapsed. As you can see, the nucleus doesn't rotate well. Look at the very thick outer shell of the peripheral nucleus. In such cases, never press down hard on the second foot pedal stage. Instead, start by carefully removing small portions of the central nucleus to reduce its volume. Using the chopper to divide it moderately can be very helpful. You'll be left with a single thick shell. Don't just try to consume it recklessly. Instead, use vacuum to secure a bulky section, then use the chopper to create support and flip the shell. This way, you can easily remove it in one piece. What about softer cataracts? In cases that are almost like crystalline lenses, simple aspiration using I and A can often remove them easily. However, if there's significant subcapsular opacity, the stickiness can make it trickier than it seems. Tilt the phaco tip downward or sideways to gently separate the periphery first. Think of it like removing a sticker. If you try to rip it off all at once, it tears. Instead, start peeling slowly and gently from the edges, so you can eventually remove it in one smooth motion. Similarly, to finish, use the chopper to apply leverage and flip the remaining shell for easy removal. Returning to this case, it's time to finish with cortex removal. You must stay focused until the very end. While the cortex may come off in one piece sometimes, there are cases like this where it comes off in small, stubborn fragments. Never rush or force it out of frustration. Take your time and aim to grab the largest possible chunks to make the process smoother. There's a famous saying about surgery: there is no such thing as a simple surgery. If today's content was even a little helpful, don't forget to hit subscribe, like, and the notification bell. Thank you.